Okay, let's talk about coagulation disorders. Um, we look at the PT in coagulation disorders, PTT, and TT. So PT, it's a test that test function of common and extrinsic pathway. So basically, common and extrinsic. So it's going to be common and extrinsic. Well, the PTT is going to be common and intrinsic. Again, what was the extrinsic pathway and what was the intrinsic pathway? Extrinsic pathway are the factors. This is the common pathway had 1, 2, 5, 7, and 10. And the PTT, all factors except 7 and 13. So let's just read the whole thing, then we'll figure out more. But here, PT, it does the extrinsic pathway and the common pathway. What factors are we looking at? All of these. Excuse me. Defects leads to increase in PT. If we have a defect in any of them, in any of the pathway, we will have an increase in PT levels. So play tennis outside, extrinsic pathway, that's the mnemonic. Play tennis, PT. Play table tennis, inside. Table tennis is inside and tennis is outside. What is INR? INR is the International Normalized Ratio, in which you have the patient PT divided by the control PT. One is normal. Greater than one is prolonged. Most common test used to follow patients on warfarin. So this is the most common test that is used to follow the patient on warfarin, which prolongs the INR. Excuse me. So warfarin prolongs the INR. Okay. And we have to check it, how much is prolonging, and we keep it in a ratio, whatever we want to keep into. Excuse me. Coming to PTT, this tests the function of common and an intrinsic pathway, all factors except 7, which was up in the extrinsic pathway, and 13. So you have 1 to 5. And then you had on the extrinsic side, you had the 9, 8, 9 actually. 8, 9, 11, 10 was here. And 7 is on the intrinsic side. So basically what I'm trying to tell you here is, we did this in the physiology. You can take a look at it over there. But PT, all are testing the coagulation factors, the factors, all the factors, right? So let's look at the TT. This measures the rate of conversion of fibrinogen to fibrin. What was fibrinogen? That was the primary platelet in the platelet plug formation. Yeah, the primary hemostasis, which was a weak plug, but when it converted into fibrin, which formed the complete plug formation, because it is cross-linked, so it is a stronger fibrin. If you don't know what I'm talking about, please look at the physiology of it. It is prolonged by, this TT is prolonged by anticoagulants, fibrinogenemias, DIC, and liver disease. Coagulation disorders, all of them they're talking about, can be due to clotting factor deficiencies or acquired factor inhibitors. Either you are deficient in clotting factors or you are inhibiting those clotting factors. Commonly, there's a factor inhibitor against factor 5, 6, 7, 8. Factor 8, diagnosed with mixing study. What is mixing study? In which you have a normal plasma added to the patient's plasma. Again, you have a normal plasma, you add that to the patient's plasma, clotting factor deficiency should correct. If you had the deficiency of, let's say, factor 8, this should correct the deficiency, right? Because you're giving normal plasma, but should correct the PT and PTT and return with a normal range. Whereas factor inhibitors will not correct. But what do they mean by that is, if you were to give normal plasma to patient plasma, this patient plasma already had, let's say, anti factor 8 antibody. So even if you give the normal plasma to this patient plasma, that factor 8 that you give from the normal is going to be eaten up by those antibodies. So you will not be able to correct the PT and APT. I hope it makes sense. Okay, then moving on to coagulation disorders, we have, what do we have? So we have hemophilia A, B, or C. Hemophilia A is 8, B is 9, and C is 11 factors, okay? And these are all in the intrinsic pathway factors. So they're all going to increase your PTT levels. Okay. And mechanism and comments. So let's read that. We have intrinsic pathway coagulation defect. And whenever we have an intrinsic pathway coagulation defect, we have increase in PTT, and that's what they mentioned here. A, if we have deficiency of factor 8, that is A, which is an X-linked recessive, pronounces hemophilia 8, EIGHT 8. That's how we know it's 8, factor 8 deficiency. B is for factor 9. Again, it's also X-linked recessive. C is for factor 11, and that is an autosomal recessive. Hemorrhage in hemophilia. What sort of hemorrhage we will see in this hemophilia? Hemorrhosis. Looking at this picture, hemorrhosis, which is bleeding into joints. Example, knee. Looking at this picture. Easy bruising. Bleeding after trauma or surgery. So look, bleeding after trauma or surgery. So you have a dental procedure, you started bleeding. What is the treatment for this all? For hemophilias? Well, treatment is give desmopressin. What is desmopressin going to do? The desmopressin is going to stimulate the endothelial production of von Willebrand factor, which has the factor 8 with it. But we will come to that in the coming things. We can give straight desmopressin. We can give factor 8 concentrate. We can give amicizumab. Or we can give factor 9 concentrate if we have B. Or factor 11 concentrate if we have C. What is this amicizumab? Well, this amicizumab, this is a it's a biphasic, well, bispecific monoclonal antibodies. What I mean by bi, specific. So it mimics. This is emicizumab mimics the activity of factor VIII by binding to factor 9A and factor 10A. So it mimics the activity of factor VIII and leading to the activation of factor 10, basically going into the coagulation cascade. Factor 10 to 10A going into the coagulation cascade. So what does it do by physics? It binds to both the factor 9A and 10A, leads to more activation, binds to factor 9A and 10 and leads to activation of factor 10A. That goes into coagulation cascade and activates that. So that's the, so you're trying to overlap the whole procedure by just giving emicizumab. I hope this all makes sense. Let's look at vitamin K deficiency now. In vitamin K deficiency, we have both increase in PT and PTT. Why? Because we have a decrease in activity of factor 2, 7. 7 prolongs the PT. 9, 10. These two are prolonging PTT and protein CNS. Vitamin K deficiency, there's a general coagulation defect. Bleeding time is normal. Okay, what are the complications? They will ask you, what are the complications of vitamin K deficiency? Complications. Well, the complication is intracranial hemorrhage. Intracranial hemorrhage. Intracranial hemorrhage. Profuse bleeding from the GI tract, the umbilicus, and the surgical site. What are the risk factors of vitamin K deficiency? The risk factors are infants have low vitamin K stores due to poor placental transfer and decrease in GI bacterial colonization. And secondly, infants who take breast milk has low vitamin K levels. Okay, that's why we give prophylactic intramuscular vitamin K to infants. That's pretty much what we have for the vitamin K deficiency. So one thing that you should keep in mind all the time, and that is, whenever you have a coagulation disorder, like a factor problem, any factor, you are gonna have deep bleeding, deep tissue bleeding. For example, look, hemorrhagitis, bleeding after trauma surgery, joints and tendons bleeding. That's the sort of bleeding you're looking at. And also you're checking the PT and PTT depending on to see which one is it, which intrinsic or extrinsic pathway we are missing. So that's pretty much it for the coagulation disorders.